So, hey everybody, hope everybody's doing well. Dr. Nitin Bhatt is going to speak to us tonight about acute respiratory failure. He's one of the pulmonologists and a good friend of mine here at Ohio State, and looking forward to hearing his talk.
All right, well, thank you. So, oops, there we go. Well, I'm not sure why it's doing that, sorry. So what we'll talk about is respiratory failure, different causes of it, how we evaluate it, and then at the end we've got some cases that we'll just go through. But basically it's a pretty simple definition. It's the inability of the respiratory system to meet the metabolic demands, and that usually boils into two components, either a failure to deliver oxygen to the tissues and a failure to regulate CO2. And this can be acute, it can be chronic, or it can be a combination of the two. Ooh, this is really annoying. I'm sorry, I'm not why it's doing those transitions. But any component of the respiratory system can result in respiratory failure or contribute to respiratory failure. And this can be anything from the central nervous system to the spinal cord and all the other nerves, respiratory muscles, chest wall, obviously anything in the lungs, and also anything in the pulmonary vasculature. So what the respiratory system does is pretty straightforward. It matches ventilation and perfusion to maintain O2 and CO2 levels. It's pretty simple, in with the good air, out with the bad air. And any of these areas can be affected and lead to respiratory failure. There's a few different types of respiratory failure. Clinically, these classifications aren't that useful, but these are kind of the big categories that you'll see. Type 1 or purely hypoxemic respiratory failure, and that's a PO2 less than 60. And if you remember the oxygen dissociation curve, remember the PO2 around 60 is where most of the hemoglobin is saturated. Once you start falling below that, then you lose that saturation. And this is the most common form. And typically you have some type of lung disease that interferes with oxygenation, but you're able to maintain ventilation. The type 2 or the hypercapnic is where you have a PCO2 greater than 45 to 50 associated with the respiratory acidosis. There's plenty of COPDers out there with PCO2s in the 60s and 70s and 80s who over time have learned to compensate, and their pH is a lot closer to normal. So you have to have the acidosis with it. This ultimately ends up being the final common pathway for a lot of these other types of respiratory failure. Once you get hypoxemic or once you hit one of the other categories that we'll talk about, eventually everybody fatigues, and once they fatigue, they don't ventilate and their CO2 climbs, and eventually they end up with type 2 or hypercapnic respiratory failure. The other categories you'll see are type 3, which is respiratory failure usually related to perioperative events. Typically this is related to atelectasis that affects lung or chest and abdominal mechanics, and that affects lung volumes and functional residual capacity. And as I mentioned, this often will lead to type 1 respiratory failure if it's with relation to atelectasis and hypoxemia, or if it's wall mechanics or muscle strength that's affected, or even just respiratory drive, you end up with type 2 or hypercapnic respiratory failure. And often most of these patients will have a combination of both of these things. Type 4 is respiratory failure that's associated with shock. And so these are patients who end up intubated as part of their resuscitation for shock. They haven't quite gotten to the point of respiratory failure, but it's clear that they're going to be unable to maintain that respiratory requirements as they deal with their hypotension and other manifestations of their shock. And so you intubate them to try and stabilize them, to unload the work of breathing in their respiratory muscles, and also to lower their O2 consumption. So there's different measures we look at when we're assessing a person's oxygenation. The first one that you're familiar with is with a pulse ox, and then you're measuring arterial oxygen saturation. And the pulse ox, as you know, has a couple of different sensors that use different wavelengths, a red and an infrared light, and takes the ratio of those to come up with a number that translate into the ratio of oxygenated hemoglobin versus deoxygenated hemoglobin. And the sat that shows up on the monitor is the proportion of the red cells that are oxygenated. The other measure is the arterial oxygen tension, or PaO2. And this is measured with a blood gas, and this is the amount of oxygen that diffuses from the alveolus into the pulmonary capillary and into the plasma. And so this is the oxygen that's dissolved within the plasma. The other measure that we look at is the AA gradient, and this is the difference between the amount of oxygen in the alveoli, or the alveolar oxygen tension, the P capital AO2, and the amount of oxygen dissolved in the plasma, the P small AO2. And this is a measure of the lung's ability to transfer oxygen at the pulmonary capillary membrane level. And it's calculated by subtracting the alveolar oxygen tension from the arterial oxygen tension. I'm sorry, the arterial from the alveolar oxygen. The PaO2 is measured by a blood gas. The alveolar oxygenation is calculated using the alveolar gas equation, and you can see the formula there. It basically involves the inspired FiO2. It's usually 21% in room air. It's the atmospheric pressure, which is 760, the partial pressure of water, which is 47, and then the carbon dioxide tension, which is measured on a blood gas, and then the respiratory quotient, which typically is 0.8, is the number that's used. And so if you plug all these things into the formula, on room air at sea level, you end up with the AA gradient being 150 minus the arterial PCO2 divided by 0.8 minus the arterial PO2. And normally there's a couple equations that you can use to come up with. The 4 plus the H divided by 4 is the most common one that we use. And that applies at room air. So as you're breathing in increased amounts of FiO2, what's considered normal increases. And so you can see there somewhere around 5 to 25 is normal on room air, and then less than 150 is normal when you're around 100% oxygen. So the goal of oxygen delivery is the amount of oxygen that's delivered to the tissues, and there's a couple measures of that. The oxygen content, which is the amount of oxygen bound to the hemoglobin plus the amount that's dissolved in the blood, and that's uses the second formula that you see listed there. And you can see the hemoglobin concentration times the saturation is the big contributor to this, to the content of oxygen in the blood, whereas the amount that's dissolved in the plasma, the arterial PO2, is pretty small. And the amount of oxygen that's delivered is that content that you calculate there times the cardiac output, and that's the goal of the circulatory system, is to deliver oxygen to the peripheral tissues. So there's several different mechanisms that are involved in hypoxemia, and we'll just go through each one of these because they all affect oxygen delivery to the tissues. Low inspired oxygen concentration. So this is pretty straightforward. It's a reduction in the amount of FiO2 that you breathe in. That decreases the alveolar PO2. That decreases the gradient for oxygen transfer from the alveolus into the artery, and the net effect of that is hypoxemia. Most common times you see this is going up to high altitude, and then the other time you'll see it in the hospital more often is that somebody's supposed to be on 6 liters and the regulator at the wall is turned off or falls off or something. So you have somebody who's chronically has a chronic oxygen requirement and isn't getting it, and so they end up hypoxemic. The next category is alveolar hypoventilation. So in this category, your lung parenchyma works okay, but you have a reduction in ventilation. As a result of that, your alveolar and arterial PCO2 both increase, and that decreases the alveolar oxygen tension. As a result, you've got less oxygen to diffuse from the alveolus into the pulmonary capillary, and you end up with hypoxemia. Now, because the pulmonary capillary works okay, if you calculate the AA gradient, that capacity of the membrane to work is okay. So you'll have a normal AA gradient even though the person is hypoxic. And the most common things that lead to hypoventilation you can see are listed here. Anything that affects the central nervous system, drug overdose is probably the most common way we see this, but certainly CNS lesions or ischemia can do it. Obesity hypoventilation can do it to some degree. These people are just so obese that the work of breathing becomes too much for them. Typically, they also become hypercarbic as well, and in addition to being hypoxemic.
Is this diminished tidal volumes essentially, or more than
Yeah, so it can be either a diminished tidal volume or it can be a diminished respiratory rate, or both. Okay. And so for obesity hypoventilation, it's generally a reduced tidal volume. They just take smaller breaths because the work of breathing just becomes too much for them. Same idea applies to people with nerve issues, ALS, Guillain-Barré, spinal cord injuries. We just saw a guy in clinic a couple days ago who had shoulder replacement surgery and had a nerve block for his procedure, and now it looks like he's got a phrenic nerve paralysis. And he came in with shortness of breath and hypoxemia. So anything that affects the nerves can do it. Anything that affects the muscles can do it. Myasthenia, polymyositis, muscular dystrophy are probably the most common ones that you see. And then people with kyphoscoliosis or anything that can affect the chest wall related to trauma, like flail chests. The most common mechanism is probably VQ mismatch. And so if you look at the figure over in the alveolus that's labeled A, you have perfusion, but you have no ventilation. At the other extreme on alveolus E, you have ventilation, but you have no perfusion. And so the ratio of ventilation to perfusion can go from nothing when there's a big mucus plug to very high when there's when there's airflow, but a clot sitting in the artery or in the vasculature. And so any partial involvement of the alveolar space or the vascular space can alter that VQ mismatch. And so you have some areas of the lung that have low ventilation compared to their perfusion, and with those areas you have lower oxygen delivery and a higher CO2 in that area. In the opposite areas where you have high degrees of ventilation compared to their perfusion, you have a low CO2 and a high O2. And the net effect of all of those is that they increase or they alter the AA gradient to various degrees. Typically, this abnormality improves with supplemental oxygen because you can overcome that mismatch to some degree with extra oxygen. The other categories include intrapulmonary shunting. So you have a small shunt normally that's physiologic, somewhere around 2 to 3%. If you have alveoli that are collapsed, or if you have somebody like this with a big mucus plug or a big pleural effusion, that's going to increase shunting through that lung, and it increases the AA gradient. Now, these people may or may not respond to supplemental oxygen as well as the people with just pure VQ mismatch do, because of it depends on the degree of shunting they have through that area, and then it also depends on the vasoregulation. So some patients seem to vasoregulate a little bit better, and they will shunt blood away from the left lung, for example, in this chest X-ray, whereas other patients don't vasoregulate as well, and they'll continue to perfuse that left lung, and they may continue to be hypoxic despite supplemental oxygen. The next category is a low mixed venous oxygen saturation. So the mixed venous oxygen levels is the average saturation of venous blood as it returns to the right heart from the peripheral tissues. And normally your tissues use about 25% of the available oxygen, and you have about 75% left over. So if you measure the mixed venous oxygen saturation, it's somewhere around 60 to 80%, and it's the oxygen that's delivered to the tissues minus the oxygen that's consumed at the tissues. And so anything that affects delivery or consumption can alter that mixed venous saturation. And the most common things that you see are listed there: anemia, if you've got a low cardiac output with cardiogenic shock, so you end up with decreased oxygen delivery, or if you have increased peripheral O2 consumption, for example, in sepsis, or is probably the most common one where you increase peripheral consumption. And as a result, when your mixed venous oxygen levels drop, you have a lower PaO2. And in general, this usually isn't happening by itself. There's something else going on. So if they're in cardiogenic shock, they've usually got pulmonary edema or something else, and they have shunting or VQ mismatch. And the same thing occurs when they're septic too. There's usually other processes in combination with this. The next one is diffusion impairment. So with this, you have oxygen that moves from the alveolus through the pulmonary capillary membrane, and that becomes altered or impaired. The most common things are anything that affects that alveolar pulmonary capillary membrane interface. So interstitial lung disease, interstitial inflammation, pulmonary fibrosis, and then anything that affects the alveolar space. So usually it goes along with VQ mismatch as well, and the combination of VQ mismatch and diffusion impairment determine how hypoxic a person gets. Some of these people who have just pure diffusion impairment are only limited with exertion. So when they're sitting and resting, even though the alveolar capillary membrane is thickened, there's still enough time as the red blood cells go through the alveolar space to pick up oxygen and maintain an adequate oxygenation at rest. When they exercise, they increase their cardiac output, the blood transit time decreases, and so there's less time for oxygenation. And the capillaries will try to respond by dilating and increasing surface area. But what happens is that may still not be enough as the red cells move through there. There just isn't enough time for them to oxygenate. So, for example, a lot of the patients in my interstitial lung disease clinic, their sats are fine when they're at rest, but they get up to walk across the room and they'll drop into the 70s or 80s pretty quickly. And for most of them, it's due to diffusion impairment. There are a couple things that give you hypoxia without hypoxemia. So the most common ones are being anemic, having a decreased cardiac output, carbon monoxide, cyanide poisoning, all affects oxygen binding, and methemoglobin, the same idea. So we talked a little bit about hypercapnic respiratory failure earlier, and again, it's a PCO2 greater than 45 to 50 with a acute respiratory acidosis. Chronically, you can have an elevated CO2, but over time, your kidneys compensate and your bicarb goes up, and you end up with a relatively normal pH. From a lung standpoint, there's a couple of things that determine what your arterial CO2 levels are, and it's in that formula there, but the main components are your CO2 production, which really which can change with increased metabolic load. So sepsis or exercise or cardiogenic shock, any of those things can alter CO2 production. Dead space and the-minute ventilation. So again, they increase CO2 production, sepsis, trauma, burns, any metabolic stress. Things that affect your minute ventilation, any component of the pulmonary bellows. So kind of going back, anything from the CNS to the nerve system to the muscle system can do it. And again, most of these will give you a normal AA gradient. Things that affect dead space ventilation, COPD, so you have areas that may not be ventilated as well but are still perfused. You have interstitial lung disease, where you have just thickening of the interstitial space and giving you dead space. Pulmonary vascular disease, all of these things will increase the AA gradient. So we've kind of been through this list already, but the CNS things that give you hypercapnia, again, anything from the central nervous system or drugs, the muscles, the nerves, the chest wall. The other thing that you may see is pleural effusions, which sort of just increase the work of breathing as the pleural effusions increase in size. it just becomes more work to breathe, so they behave as if their lung volumes are smaller or if their muscles are weaker. Eventually they fatigue also and end up with hypercapnic respiratory failure. A lot of medical diseases can go down the same pathway, and you can see the list there, but any pulmonary disease will do it. Cardiac disease with pulmonary edema will do it. Hypoventilation, hypothyroidism, many of these things can give you hypercapnia as well. So when you're looking at the patients with acute respiratory failure, the evaluation typically includes history, a physical exam, and then some pertinent studies. As far as history, the most common things you want to know, any recent symptoms or specific triggers of the person's symptoms. Is this a new problem, or is this something that's been going on for a while? Do they have other conditions that may predispose to this, asthma or COPD or underlying heart disease? Have they ever had something similar to this before? And if they have had something similar, does this feel the same or does this feel different? Have they ever been intubated for other medical conditions? Did their symptoms develop suddenly or kind of progress over the last few hours or last few days? What other symptoms did they have associated with that? And then you always want to look at their medications. In the hospital, narcotics are probably the most common reason people get into trouble. Ooh, sorry. So the things you look for when you're actually examining the patient, you can usually tell pretty quickly just walking from the room to the bed to figure out if they're having respiratory distress or not, and typically they have that look. You see their sternocleidomastoids kind of flaring with every breath. You see them being cyanotic. They're usually tachypnic, and that's a good sign. If their sternocleidomastoids are flaring and they're cyanotic and they're not tachypnic, that's even worse. If they're tachycardic, again, that's good. If they are bradycardic, that's even worse. And then normally when you breathe, your chest and your belly go in the same direction. If things start moving in opposite directions, they've kind of given up on any normal physiology, and they're just doing whatever they can to get the air in. And that's usually a sign of impending respiratory distress. So these are the things that you'll see. Usually they're anxious and agitated. Often they're diaphoretic, cyanotic, sitting upright or tripoding with their forearms resting on their knees or resting on their thighs and leaning forward. They're usually anxious or irritable, but if they're somnolent or confused, those are usually bad signs that they're starting to develop hypercarbia in addition to their hypoxemia. And patients can compensate for one or the other for a little while, but when they start getting both, that's usually a bad sign. You can look at the breathing pattern. Normally, a respiratory rate somewhere between 10 to 20 and an expiratory pause. If they start having labored breathing, usually you'll see a slow respiratory rate but large tidal volumes. Over time, that gets worse, and they end up with just a quicker rate and smaller tidal volumes, and then eventually they just give up and they have small tidal volumes and a small respiratory rate. The other patterns that you see, the common ones are chain Stokes, and that's the crescendo-decrescendo pattern that you can kind of see in the figure at the top there. The most common things that cause that are underlying cardiomyopathy or heart failure, or CNS lesions will give you that breathing pattern. In the sleep clinic, we see people with heart failure who come in for sleep studies to look for sleep apnea who breathe like this normally, and they don't even realize that they're doing it. But it can also be a sign of respiratory distress if it's more acute. The other one that you probably see a lot in the hospital is the Kussmaul breathing, and that's just large tidal volumes at a rapid rate, and typically associated with a severe metabolic derangement, usually a metabolic acidosis. So these patients just are chugging away. They're taking as deep a breath as they can, just over and over and over again. You keep waiting for them to stop and slow down and take a break, but they just keep going. And typically they do have a significant acidosis. Their pH will be 7, 7.1. Their CO2 will be in the teens. Their bicarb is usually in the single digits. most commonly it'll be like TKA patients or cirrhotics or someone getting septic. They usually just have such a huge metabolic demand that they have to blow off that much CO2 to try and maintain a reasonably normal pH. So other signs of distress, the flaring nostrils, the pursed lip breathing, accessory muscles. So if you see retractions of their sternocleidomastoids or suprasternal muscles or intercostal muscles, those are all bad signs. If they have the paradox, that's a bad sign also. Generally, the vital signs can give you some idea of how sick they are. If they're febrile, you always worry about pneumonia or sepsis. If their SATs are low, obviously you're looking into that. But if they're very hypotensive or hypothermic, it may not completely correlate. And you want to make sure that the heart rate that shows up as you're checking their pulse is what shows up on the pulse ox monitor. If the heart rate and the pulse doesn't correlate, they may be significantly hypotensive, and it may not necessarily be accurate, or it may just not be reading accurately. Carbon monoxide poisoning or methemoglobinemia can also affect the saturation. If their blood pressure is low, that's a really bad sign. So if they're dyspneic or tachypnic and hypotensive, there's something bad's usually going to happen relatively quickly. Taking a listen to them can give you some idea of what's causing the respiratory failure. If they're stridorous, usually you worry about airway obstruction. Inspiratory stridor can be something involving the vocal cords or something above the vocal cords, aspiration or epiglottitis or angioedema. If they have expiratory wheezing or a combination of inspiratory and expiratory sounds, it often can be something below the vocal cords, but it's not necessarily that distinct demarcation between those two signs. If they have crackles, you always worry about some kind of alveolar process. Usually, if it's fluid filling the alveoli from pulmonary edema, if it's pus from a pneumonia, or they may just have crackles related to some kind of pulmonary fibrosis or interstitial lung disease. Wheezing most often is asthma, but not always, and probably the most common other thing that it ends up being is early heart failure. So we certainly see a lot of patients with early heart failure or pulmonary edema who present with wheezing, and so you always have to be aware of that when you hear somebody wheeze. And then decreased breath sounds can be related to asthma or COPD exacerbations where they're just not moving enough air to make regular breath sounds or even to wheeze, or they could have a pneumothorax or a pleural effusion that's just masking the breath sounds. Cardiac evaluation, you're looking at the heart rhythm, murmurs, gallops. Do they have an elevated JVP? Do they have a pulsus paradoxus? Do they have lower extremity edema? Are they cool and mottled, or are they warm and vasodilated? It can help you figure out between the different types of shock. Are they having pain? So some patients will have pleuritic chest pain associated with their symptoms. If you hear a friction rub, then you always worry about some pleurisy or some pleural process, but it may also be related to pulmonary infarction from a pulmonary embolism. If they have central pulmonary chest pain, it may just be related to coughing and asthma. It may be related to pulmonary hypertension. It's not as useful a sign. And then chest wall pain, you think more neuromuscular, or you think more musculoskeletal sources. So the evaluation of somebody who's in respiratory distress usually begins with a blood gas, a chest X-ray, some basic labs, and an EKG. The blood gas helps you assess the severity of the gas exchange abnormalities. How hypoxic are they, and are they having hypercarbic issues as well? And it can help you with the chronicity of the respiratory failure based on their pH and their acid-base status. And also it can give you an opportunity to calculate the AA gradients and help differentiate between the various causes of hypoxemia and hypercarbia. Chest X-ray helps you try and figure out what's going on. Typically, it's divided into things that have pulmonary parenchymal involvement and things that have a relatively clear chest X-ray. So when you see a chest X-ray with patchy infiltrates, as you all know, you worry about aspiration or atelectasis or pneumonia. You worry about some type of interstitial lung disease, such as organizing pneumonia or various kinds of fibrosis. Pulmonary embolism or pulmonary infarction can give you patchy infiltrates as well. If you see an X-ray like this with diffuse infiltrates, the most common categories are either acute lung injury or ARDS, diffuse aspiration. There are some interstitial lung diseases that can give you this type of pattern. Things like acute interstitial pneumonitis, which is an acute or accelerated version of ARDS. Eosinophilic pneumonia can look like this. Pulmonary alveolar proteinosis can look like this. The other categories are alveolar hemorrhage, pneumonia, pulmonary edema, transfusion reactions can look like this too. So basically anything that's filling the alveolar space, whether it's fluid, it's blood, it's pus, protein, are the usual kind of big categories that you see. So somebody who has a clear chest X-ray and is hypoxic, the differential is a little bit smaller. Asthma and COPD are probably the most common ones. Pulmonary vascular disease, pulmonary hypertension can do this. Pulmonary embolism, air embolism is not as common, but certainly it can give you respiratory distress in a clear chest X-ray. If they have a clear chest X-ray and they're hypercapnic, you worry more about the asthma, COPD, but you also have to think about the neuromuscular disease, CNS lesions, obesity, hypoventilation, or overdose, anything that's going to, affect the pulmonary bellows. So the labs, in addition to the blood gas, usually it's serum chemistries and a CBC, cardiac enzymes to rule out some type of cardiac events. You can do a BNP to help differentiate heart failure, although some patients who have chronic kidney problems or even acute kidney problems, their BNP may be elevated pretty early in the process, and it may not be as helpful then. If you're in the outpatient office or in the emergency department, a D-dimer is more useful than it is if you're in the inpatient world. Most patients in the hospital have elevated D-dimers, so it's less useful. And then in the emergency department, you always worry about overdoses, and so a tox screen is pretty common. You look at the EKG for arrhythmias, and then the radiologic studies that we've kind of already talked about. So the next step is, while you're waiting for some of these things to come back, is managing the respiratory failure. Early in the process, it's the ABCs. You want to make sure that they have an adequate airway. The primary goal is to reverse or prevent the hypoxemia, and then the secondary objective is to work on the PCO2. Support the circulation as needed. So if they need pressors, you do whatever you need to do. Venous access, if you do need to start them on pressors, and then treat any underlying diseases that you can come up with. So the airway assessment is pretty straightforward, and the things that you're looking for are how awake is the person, are they in shock, or are they having hemodynamic issues or cardiac instability, and are they able to protect their upper airway? Do they have an adequate cough or gag? And then you look for any signs of upper airway obstruction. So if they're able to protect their airway or maintain an airway, then the next step is to work on oxygenation. If they're unable to protect their airway, then intubation is what's needed. As far as oxygen therapy, you titrate the amount of oxygen to their SAT, their PO2, and their PCO2. And their goal is to try and prevent tissue hypoxemia, and you want to maintain adequate oxygen delivery to the tissues. So you try to keep their arterial PO2 somewhere in 55 to 60 range, or a SAT greater than usually 88 to 90%. We always worry about giving supplemental oxygen to COPD patients, but really it's not that big a concern for most of the patients. A very small fraction of the patients will develop problems, but typically we don't withhold it on other people. We give them the oxygen, and it looks like they're having problems, and you can always turn down the oxygen. And in these people, we will accept a little bit lower PO2 and a little bit lower SATs, and even down to 86, 88% sometimes for them. So the different approaches for patients who are primarily having an oxygenation failure include supplemental oxygen, non-invasive ventilation with CPAP or BiPAP, and then mechanical ventilation. There's different ways you can give supplemental oxygen. Most common is just nasal cannula, and that's generally anywhere from 1 to 6 liters, and the amount of oxygen increases by about 3 to 4% with every liter increase in flow. And once you start getting up above 6 liters, it becomes a little bit difficult to tolerate. There are new high-flow nasal cannulas that will go all the way up to 15 liters. It's a little bit hard to figure out how much oxygen a person is really getting when they're breathing through a nasal cannula that's getting 10, 12, or 15 liters of flow. If you look at this graph from a study from a few years back, you can see at about 6 liters, it's anywhere from about 50 to 60% if they have their mouth open or their mouth closed, and that goes all the way up to about 70 to 80% if they're up around 15 liters. The next step up from the nasal cannula is the veni mask, and so these are, you can see on the figure at the bottom, there's some numbers and some markings, and you can adjust it to mix a specific volume of airflow from the room with oxygen. And so you can a little bit more precisely deliver certain amounts of oxygen, and it can be anywhere from 24% all the way up to 60%. The next step up from there are the non-rebreather masks. And these masks have a reservoir bag that fills up with oxygen, usually at high flow at around 15 liters, and that gets mixed in with the air as they breathe. Now there's two types. There's the non-rebreather, which is on the bottom on the figure on the right, has several one-way valves, one from the bag into the patient's mask, and then a couple exhalation one-way valves too. And that prevents expired air from diluting the oxygen that's in the reservoir bag. And so you can get pretty high oxygen concentrations, anywhere from 75 to 90% with the non-rebreather. If you take those one-way valves away, you end up with a partial non-rebreather. So you get mixing of that high oxygen concentration in the reservoir bag with air from the room or exhaled air. And so that's a little bit lower, anywhere from about 40 to 60%. Regardless of which of these you use, you need a good seal around the patient's nose and mouth, and then the bag shouldn't collapse. So if the bag's collapsing with every breath that the person's taking, it's not really clear how much oxygen they're getting at that point. You can turn up the flow as high as it'll go, but if they're still collapsing the bag, then their demands are just so high that you're probably not going to be able to keep up with this type of with less invasive types of oxygen delivery. So the next step up from the non-rebreathers is some type of positive pressure ventilation. And this can be non-invasive with either a CPAP mask or a BiPAP mask, or it can be more invasive with an endotracheal tube and mechanical ventilation. The CPAP or the BiPAP are both types of non-invasive positive pressure ventilation. And so with this, you have delivery of mechanically assisted breath without an artificial airway. And it has had very good success in the right patients, and it's been shown to affect mortality, hospital stay, and the need for mechanical ventilation. It works by improving alveolar ventilation, not so much by altering the respiratory rate, but it affects the tidal volume. So for the same amount of work, they get a larger tidal volume, and you end up reducing the work of breathing, and you also take the load off the respiratory muscles, so it rests them. In addition, it increases intrathoracic pressure, and that can decrease preload, so it can affect the blood pressure some, but it also decreases the afterload, the transmural pressure across the left ventricle, and so you have some cardiac effects with it as well. And the studies have shown that there are certain scenarios where you have benefit from this more than others. The most common ones are acute exacerbations of COPD, patients with heart failure or cardiogenic pulmonary edema, patients with asthma, although the results are a little bit mixed there, Patients coming off mechanical ventilation, you can use CPAP or BiPAP to kind of rest them a little bit as they transition from a mechanical vent to breathing on their own. And some immunocompromised patients that you're trying very hard not to intubate, you can use non-invasive means to try and get them through. So CPAP delivers one pressure with during both inspiration and expiration. Typically, you start at a pressure of around 5, and you go up in steps of 3 to 5 centimeters, depending on their response as far as their oxygenation and their work of breathing. Once you start getting up above about 15 centimeters of water pressure, it just becomes more difficult to tolerate the mask and the pressure, and patients usually have a difficult time tolerating that. We use this all the time in patients with sleep apnea. It works very well for oxygenation failure, so people with pulmonary edema, and patients with some pneumonias, you might be able to get them through as well. For pneumonias, it seems to be it helps with the hypoxemia, where they typically run into problems with secretions and cough and managing that part of pneumonia, and that's usually what gets them intubated. You can get a lot of people through just from a hypoxemia standpoint with just CPAP or BiPAP. And then we've talked about effects on cardiogenic pulmonary edema. It decreases preload, it decreases afterload, and it decreases myocardial oxygen demand, so it can have a lot of positive effects in patients with pulmonary edema. With BiPAP or bi-level non-invasive positive pressure ventilation, you get two different pressures, a higher pressure with inspiration and a lower pressure with expiration. Typically, we'll start with an inspiratory pressure of somewhere around 10 and an expiratory pressure of 5. You increase the inspiratory pressure in steps of 3 to 5 based on usually for hypercarbia is the most common reason that we'll use bi-level as opposed to, or use BiPAP as opposed to CPAP. And so you increase the pressures and you can follow their blood gas and get an idea if their ventilation is improving and their CO2 is decreasing, then they're doing well. You can, if they're not, you can try increasing the inspiratory pressure to try and increase the tidal volume. Now, for patients who are both hypercarbic and hypoxemic, you can increase the inspiratory pressure to help with the CO2 part of it, and then you can increase the EPAP or the expiratory pressure to help with oxygenation. And you can see this is beneficial in COPD patients, the cardiogenic patients, and also in immunocompromised patients. So this technique works really well, but there's some patients that it just shouldn't be used for. And the most common ones are cardiac arrest or any kind of cardiac instability. So if they're having heart rhythm issues, or if they're having hemodynamic issues, you're better off, and you get to this level of support, you're better off just intubating them. If they have an altered mental status, or if they're unable to protect their airway and clear those secretions, those patients need to be intubated too. Patients with facial trauma who just won't tolerate a tight-fitting mask, or patients who are having active GI bleeding and you're worried about them throwing up or aspirating, this isn't a technique that's going to work for them either. The other important caveat with non-invasive ventilation is that it's something that you have to watch close. So you can't just put somebody on BiPAP and then come back and check on them 6 hours later. You need to go back and look at them a half hour later, an hour later, and see do they look better or not. And is their respiratory rate improving? Is their O2 improving? Or their CO2 improving? A lot of times we'll go back and look at them, and they're kind of sleepy, and they look like they're resting, and they look like they're a lot more comfortable. But you draw another blood gas, and the reason they're comfortable is that their CO2 is even worse now, and their pH is even lower. So if they fail to improve, that's a failure of non-invasive ventilation, and they need to be intubated. And that's the highest level of support is mechanical ventilation. And this is for patients who can't maintain an adequate airway or who have altered mental status, who you can't oxygenate or ventilate by any of the other means that we've seen. Patients with any type of hemodynamic instability, and then patients with neuromuscular disease. If they have a vital capacity that's less than about 20 cc's per kilo, or if their maximum inspiratory pressure is more positive than the -30, or if their maximum expiratory pressure is less than 40. All three of those things are signs that they just have an ineffective cough. and so they can't clear their secretions, and ultimately they're either going to mucus plug or aspirate, and so those are people that need to be intubated. And so once you've supported them either with oxygenation or non-invasive or with intubation, then you're looking for and trying to treat the underlying cause. So we'll just go a few cases that bring up some of the different processes that we've talked about. The first one's a 60-year-old gentleman who's got end-stage renal disease and becomes acutely short of breath. You walk in to see him, he's alert, he's awake, he's sitting upright in bed, he's breathing 40 times a minute, his blood pressure is 200 over 100, and his sats are 84% on a non-rebreather. On exam, he's got diffuse crackles. So the most common things that are going to happen when somebody's blood pressure is that high and has got crackles, most likely they've got pulmonary edema, especially if it happens acutely in somebody who's very volume sensitive, as the renal patients are. So you get a blood gas and a chest X-ray, and this is typically what you see. He's tachypnic, so he's alkalotic. You see diffuse infiltrates on his chest X-ray. So this is probably somebody who just had a pulmonary edema secondary to end-stage renal disease and a hypertensive emergency. Since they're alert and awake and hemodynamically stable, you have some time. You can try non-invasive ventilation with CPAP to help him with his oxygenation. You can start medications to try and bring down his blood pressure with nitrates or nicardipine or something else. And it's also important to rule out an acute cardiac event in these patients, and then also try and get some fluid removal through either diuretics or dialysis to try and get them through. The next case is a 60-year-old woman, a smoker, who develops an upper respiratory tract infection with cough, fever, and chest tightness. She's able to tolerate her symptoms for a couple days, but then decides to come into the emergency department because she's not getting any better. You can see she's febrile, she's tachycardic, she's tachypnic, and she's hypoxic. On lung exam, she's got diminished breath sounds, but with some expiratory wheezing. On her blood gas, you can see she's hypoxemic with a PO2 of 42. She's hypercarbic with a PCO2 of 72, and her pH is of 7.32. So even with the CO2 being that high, her pH isn't terribly low, so she probably lives with a PCO2 in the 50s or so. She has a white count. Her chest X-ray doesn't show any obvious pneumonias, but it certainly looks like somebody who's got COPD. So she probably has bronchitis and a secondary COPD exacerbation. She's also awake and hemodynamically stable, so she's able to protect her airway. And so this is somebody that you can probably get through with supplemental oxygen and non-invasive ventilation like CPAP or BiPAP while you're waiting for the inhalers and the steroids and the antibiotics to work. She improves initially, but then acutely decompensates. And as you can see from the chest X-ray, she has a large pneumothorax on the left side, which is something that you always worry about in COPDers anytime you're using any kind of positive pressure ventilation, whether it's a BiPAP mask or mechanical ventilation. A pneumothorax occurs fairly commonly. The next case is a 52-year-old gentleman with pancreatitis. He's being treated conservatively. He develops progressive shortness of breath and hypoxemia and ends up on 100% non-rebreather. You can see his PO2 is 90 on 100%. He has a respiratory alkalosis and an increased AA gradient. And this is his chest X-ray. And you can see he's got diffuse infiltrates and ARDS. So this is always something to think about in patients, especially in the hospital, who develop progressive infiltrates and progressive respiratory failure. Most common reasons that we see in the hospital or in general are pneumonia, aspiration. It can be secondary to any source of sepsis. You see it in trauma patients with pulmonary contusion or fat emboli. You can see it in drowning injuries as well. The less common causes that you see there include bypass, transfusion reactions are actually more common, and then pancreatitis and drug overdose as well. So ARDS is diffuse damage to the gas exchanging surface, either on the alveolar side or the capillary side, or it can be in both. You get altered vascular permeability, and you get fluid shifts and a non-cardiogenic pulmonary edema. So the interstitial space and the alveolar space fill up with fluid and red blood cells. All the proteins kind of coagulates, and you get hyaline membrane formation. In the alveolar spaces, you lose surfactant concentrations, and you get collapse of the alveoli. Now you have shunting as well. And so they end up with bilateral pulmonary infiltrates. You don't have other underlying cardiogenic causes of the infiltrates. If you look at their PF ratio, so the ratio of their arterial PO2 to the FiO2, less than 200 is considered ARDS, less than 300 is acute lung injury. There's a significant mortality associated with ARDS. The treatment is usually supportive, treating the underlying cause, early antibiotics, and mechanical ventilation. Really the only thing that's been shown to be helpful in these patients is low tidal volumes. You'll hear a lot of the 6 cc's per kilo, which is what the studies have shown, and increased levels of PEEP to try and improve their oxygenation. The next case is a 38-year-old man with a history of asthma, has had 3 days worth of nausea, vomiting, diarrhea, fevers, chills. Is admitted for dehydration and has a flu swab that's positive for influenza. You can call it to see him because he's having increasing shortness of breath. He's wheezing, and his sats are in the mid-80s. If you look at his vital signs, you can see tachycardic and tachypnic. His blood pressure is okay. He is hypoxemic on 6 liters, but he's reasonably stable there. He has diffuse wheezing on exam. You get a blood gas on him, and you can see his pH is pretty normal at 7.38. His PCO2 is slightly elevated at 43, and his PO2 is 84. There's a couple of things to be concerned about when you look at his physical exam and his numbers. He likely had an asthma exacerbation that's triggered by the flu. He's breathing 32 times a minute, but his CO2 is actually elevated. And that's a bad sign in asthmatics or in people with COPD exacerbation, or actually in anybody. If you're breathing 32 times a minute, your CO2 should be low, and you should have some degree of a respiratory alkalosis. When you start seeing the CO2 climbing in somebody who's tachypnic like this, you always worry about impending respiratory failure, and this is somebody that needs to be moved to the ICU, and somebody you could try non-invasive ventilation on to see if you could bring their CO2 down and help them get through this. So the next one's a 47-year-old African-American woman who's on chronic immunosuppression for lupus. She gets admitted to the hospital with shortness of breath, hypoxemia, and infiltrates on her chest x-ray. She undergoes a bronch. She gets a little Versed and some fentanyl for the procedure. She gets some viscous lidocaine and some benzocaine spray prior to the procedure. During the bronch, she's noted to have diffuse secretions and a pneumonia. Post-procedure, she's noted to be cyanotic. Her stats were in the mid-90s and dropped into the 70s. She's placed on a non-rebreather, and her pulse ox settles out to about 84%. You get a blood gas on her, and her PO2 is actually relatively normal, and her calculated oxygen saturation is 100%. Her blood sample looks cyanotic. So this is someone who has a gap between their measured saturation and the calculated saturation. And a couple of things that you think about with this are methemoglobinemia and carbon monoxide. In the hospital, it's almost always hemoglobinemia, usually related to some medication. In this case, we did a methemoglobin level off her blood gas, and it was elevated at 24%. The treatment for this is methylene blue, and most patients have a very good response relatively quickly with methylene blue. So with methemoglobinemia, the hemoglobin changes from +2 iron to +3 iron, and it doesn't bind oxygen as well. The affinity of the oxygen to the hemoglobin is increased up to the normal hemoglobin is increased, and so the normal hemoglobin is less likely to give up the oxygen into tissues. So you have decreased oxygen being carried there, and then you have decreased oxygen being unloaded at the tissues as well. Most common things that do this are sulfa medications, are lidocaine, and then nitrates can do it as well. And symptoms or anything due to impaired oxygen delivery, so it can be minor, things like headaches or fatigue or dyspnea or altered mental status, or it can be more severe, including respiratory distress and cardiac issues. So one of the things that you'll see with methemoglobinemia is that the pulse ox will kind of settle out at about 85%. So the methemoglobinemia, if you look at the figure, the dotted line here on the top is the methemoglobinemia. It absorbs the two different frequencies of light relatively equally. And in addition, when you combine that with the normal oxyhemoglobin and the deoxygenated hemoglobin, the average of all these three things settles out at about 85% on their saturations. Now the problem is if they're more hypoxic than 85%, it can overestimate what their SAT is, or if their SATs are actually greater than 85%, it underestimates. So you're never really quite sure what it is. It'll just kind of hang out in the mid-80s. So this is something you always think about when somebody's SAT is in the mid to low 80s, but their PO2 and their calculated SATs and their measured SATs are better. So if you have the gap between those two, you always worry about methemoglobinemia. The next case is a 44-year-old man with a recent viral illness who's admitted and has progressive lower extremity weakness. He's diagnosed with Guillain-Barré. You're called to see him because he's dyspneic and his SATs are in the mid-80s. He's tachypnic. He's taking shallow breaths, but his lungs are relatively clear. You look at his X-ray, and his X-ray is normal. You get a blood gas on him, and you can see his pH is low at 7.18. His PCO2 is elevated at 68, and his PO2 is low at 49. If you work through the calculations there, you can see that his alveolar PO2 is 65. His arterial PO2 is 49, so his AA gradient is 65 minus 49, or 16, which is relatively normal. So his hypoxemia is most likely just due to hypoventilation from his neuromuscular disease. The next case is a 77-year-old woman with stage 4 non-small cell lung cancer. She gets admitted with a symptomatic malignant pleural effusion. On the first day of her hospitalization, she has fluid drained and she's on 2 liters of oxygen. By the next day, however, the fluids recurred, and the plan is to place a Pleurex catheter on the 3rd day. Overnight, she gets more short of breath. She has an increased O2 requirement. She has a temperature of 101.1. She's tachypnic. She's tachycardic. Her blood pressure is a little low at 90/50. If you look at her blood gas, you can see she's got a CO2 of 19, a PO2 of 80, and a bicarb of 11. Her chest X-ray shows reaccumulation of the fluid on the right-hand side, but otherwise doesn't look too much different. So this is somebody who's febrile, who's a little bit hypotensive, and if you look at their blood gas, she is hypoxemic, but she's got a respiratory alkalosis and a metabolic acidosis. And this is someone where it's probably not so much a primary, probably not related to the pleural effusion or to malignancy, but someone who's more septic. And sepsis or SIRS are kind of a spectrum of disorders. SIRS is the systemic inflammatory response, and that's a clinical manifestation to various insults, the most common one being some kind of infection. The criteria for SIRS are 2 of 4 of the ones that are listed there. So either they're febrile, or they're hypothermic, and they're tachycardic, or they're tachypnic and have a low PCO2, and they have either an elevated white count or a low white count with immature forms or bands, and they're differential. Sepsis is the SIRS criteria and at least one sign of inadequate organ perfusion. And the ones that you'll typically see are either altered mental status, hypoxemia, and elevated lactate, or decreased urine output. And this is probably the most common reason why you'll see respiratory distress in patients in the hospital, and it's important to always consider sepsis in these patients. Because often you'll see them early in the day, and the only sign that you may see is looking at their vital signs. They may be a little bit more tachypnic, and it's usually a sign of having increased metabolic demand from the underlying infection. They're tachypnic to try and maintain their CO2 balance, and they can compensate for a little while, but over time they lose that inability to compensate, and that's when you start seeing the other signs of organ dysfunction. Usually they start becoming hypoxemic, or they have an altered mental status, and those are signs of progression from the SIRS to sepsis. And I think that's it. Questions?
I had a quick question. So in COPD patients with a significant amount of emphysema change, do you have a higher risk of pneumothorax development with non-invasive positive pressure ventilation or with mechanical ventilation?
That's a good question. It's probably with mechanical ventilation.
Okay.
I think with the non-invasive, the overall airway pressures are still lower than they are with mechanical ventilation. So I would think mechanical ventilation is more likely to give them barotrauma or pneumothoraces or stuff like that. Okay.
Okay. And with mechanical ventilation as well, such as an ARDS in younger patients, the significance of the risk of barotrauma. I mean, you mentioned calculate the tidal volume at 6 cc's per kilogram, I think.
Right. Yeah.
So above that, you have a significant risk of barotrauma and consequences or adverse events down the line, or?
Yeah, in the short term and in the long term. The ARDS studies that looked at that looked at 6 cc's per kilo and then compared them to higher ones, either like 10 to 12 cc's per kilo. And the ones who got the lower tidal volumes did much better. There are a couple of things that you can look at on the ventilator. The plateau pressure is what we measure and follow, and a plateau pressure less than 30 is what you'd like to see. And that was the other part of the criteria, is about 6 cc's per kilo, and then you follow the plateau pressure, which is something that you can measure off the ventilator, and you try and keep that below 30.
Okay.
And the other important thing is that it's 6 cc's per kilo per ideal body weight. So we get a lot of people who come in who are 350 pounds, and people trying to work out the 6 cc's per kilo, and that's still too much. It's for 6 per kilo for ideal body weight for their height.
Okay, I appreciate it. That's great to know. Any other questions anybody has? Okay. Well, thanks, Dr. Bhatt. That was fantastic as usual. That was a great talk and very insightful. And hopefully, I can meet the bar a little bit better when it comes to acute respiratory failure in the future. So.
All right. No problem.
Great. Thank you, Dr. Bhatt. We really appreciate it.
No problem. All right. Take care.
All right.